Welcome everyone to the second Europe-Africa Health Summit. Following the successful first summit, it was very clear that skills for health, skilling up the health workforce was an extremely useful topic where both Europe and Africa can exchange ideas. My name is Dr. Amit Thacker, and I am the president of Africa Healthcare Federation. Formed over the last 15 years, countries in Africa realized in order to get the voice of the private health sector unified in a country, all non-state actors needed to come together to engage government constructively. With a success story in some countries in East Africa, this model was replicated in West Africa and now being replicated in Central, North, and South Africa. On the course of our journey with the 55 countries, partners like Europe, who we've done business with in healthcare and partnered with for scientific knowledge and policy, came forward, and we gladly accepted this partnership with the ECH Alliance. We have walked the journey together, especially in the last 2 years. The pandemic has taught us that we don't need to travel to exchange ideas. We don't need to move from country to country to ensure we have the right kind of knowledge and treatment being offered. And this strength of collaboration is one key pillar in our new public health order. Today, it's a real pleasure for me and Brian to be hosting an esteemed panel. We have two very powerful keynote speakers who will share brilliant initiatives and ideas from both continents. Europe and Africa will continue exchanging and collaborating, especially when it comes to the workforce. I think the kind of workforce we will see after the pandemic, which was the largest wake-up call for all of us, will be a different kind of workforce. We'll be giving rise to digital health specialists who we probably didn't have in our hospitals before. We'll have health digital technicians. We'll probably have pharma digital specialists. So we know that that kind of cadre is going to transform economies, sustainable businesses, and stewardship at the ministries of health. I know the academia are thinking of changing the curriculum. So I want to learn today. I'm going to sit back and I'm going to listen to the keynote speakers and the panelists and absorb what I believe could be the beginning of transformation on workforce on the global scene. I am delighted to partner again with several colleagues and ECH Alliance. I would now like to invite Brian O'Connor, who's an extremely active and a champion from the Europe continent, to say a few words. Brian, the podium is yours. Thank you.
Thanks very much indeed, Amit. It's a pleasure to be back here at this second summit. You've summed it up very well. What I've learned during the pandemic is, first, it's difficult to get a workforce anywhere, not just in Africa, but across the world. There's a huge shortage. Secondly, as you say, it'll be a different type of workforce, which will require different skills. And we need to be well prepared to deliver that opportunity, both in Europe and in Africa. So I would leave it at that for the moment, because we'll jump in and out with questions later. But I'm absolutely delighted that once again, we have a representative here from the European Commission in Brussels, Maya Matthews, who will introduce herself. And Maya, I know you're deeply involved in this area, so we'd love to hear from your perspective and your keynote to tell us the direction of travel. So if I may, over to you, Maya.
Thank you very much. Good afternoon, everyone. I'm really honored to be here and already hearing such inspiring words from you, Brian, and also from Dr. Tucker. For us, obviously, in the European Commission and the EU as a whole, as you know, the COVID pandemic has really shone a spotlight on health in general, but especially on the health workforce. And of course, we really need to recognize, as you said, Brian, that healthcare shortages have been a huge hindrance in our response to the COVID pandemic. A recent report that the European Commission published, along with 29 country health profiles, actually put health workforce and reskilling and upskilling as one of the key takeaway points that we need to learn from this pandemic. In this report, we had health profiles from 29 countries, and 15 of those countries referred to healthcare shortages as one of the key challenges in their healthcare delivery during the pandemic. Just to give you an example of the kind of great variety within the European Union that we're talking about in terms of health workforce. Across the EU, we have a difference from 2.4 doctors per thousand population to 5.3 per thousand population. And even within countries themselves now, I'm sure that this reverberates very well with all of the participants, but even within countries, we have something so-called medical deserts, where there is really very low coverage by health professionals. If we turn to nurses, the situation is even more acute, and the variety in terms of nurses per thousand populations differs by a factor of 4 across Europe. In addition, we are hearing more and more worrying signals that nurses are leaving the profession. The last 2 years of addressing the pandemic is exacerbating an already depleted workforce. So the rate of attrition and burnout is really worrying. So you may ask, for the European Commission, as you know, we support member states. It's up to each country to organize the way their health care system is organized and delivered and who they recruit. So from the European Commission's point of view, all we can do really is to encourage, advise, and to support member states and kind of create a more enabling environment, I would say. For me, as a public health professional for many years, I think that the whole area around skills of what makes up a health system really needs to be looked at again. From the pandemic, we've also seen not only has the health workforce been in the spotlight, but public health as a profession has been in the spotlight. And I also hope now the fact that, you know, on the news in at least in Europe, we had epidemiologists taking like full coverage news and press conferences. I hope that this has also inspired a new generation to get more interested in epidemiology, in public health, and also health service delivery. I wanted to focus a little bit on the subject at hand, which is skills. And within the EU, we have a very big package about called the Skills Agenda, which is really looking at how we can transform, upskill, reskill, across 14 different ecosystems in Europe in order to make Europe a more innovative and productive economy. Health, of course, is one of the ecosystems. So we launched in February 2020 a so-called Pact for Skills Roundtable, where we brought together public and private sector, think tanks, professional associations, NGOs, including patients groups, to actually ask them, you know, what were the health skills challenges and what were the solutions. And I just want to briefly summarize the 3 main points that came out of it. Digital skills very, very strongly, with the caveat, and I think that this is worth mentioning, that for the health professional associations at least, it's very important that digital skills facilitates the work of the health workers. It shouldn't be seen as an extra burden. What they said in all of our discussions that we've had with professional associations is that the digital skills should be a way to give them more face time with the patients and not be stuck behind a screen filling out forms. The second issue is about the communication skills and the patient professional relationship, and how this has changed so much with more kind of self-monitoring, self-care. You know, it's not so much, we have to really think a little bit now about the different roles that health professionals play in looking after their patients. And finally, also skills around preparedness, around emergency care. And here I want to give you an example of something that we did, we funded quite early on in the pandemic, where we worked with the European Society of Intensive Medicine, and we funded them to carry out a very short course on intensive care training, because what we found in Europe, at least, is that many of the health professionals did not have the skills to work in intensive care units. And as you know, in the beginning, at least, of the pandemic, and unfortunately now we're in the fourth wave, this is also happening, we didn't actually have enough people skilled in intensive care units. And this proved to be a very good model, because in all, 17,000 health professionals were trained across all of the 27 EU member states. So this, we thought, was a very good model to share, where we can really focus on a very specific issue. And as a result, we are now launching, or we are just about to launch, a bigger training package using this kind of model, but really it's a call for proposals to different professional associations to identify areas where they feel it's important to carry out continuous professional education. And we're doing this really as we're casting the net very wide, because we think it's the individual professional associations who know best where they need to focus in terms of developing extra modules on digital skills, or even other areas. So this is something that we've just launched in our new work plan 2021 for the EU for Health program. And we really hope that this will provide some really action on the ground. And one of the areas in this Pact for Skills Roundtable was the fact that many organizations felt there wasn't enough funding or capacity for continuous professional education. And often they had to turn to kind of the industry, where it was sometimes linked to using a specific product or software. So our idea here is to really develop this area and to really get the people who are training their sector to do this. And we've also opened it to non-clinical, as I said, like people working in hospitals who might not have a clinical function, but it's very important nowadays, especially in digital skills, about innovative procurement models, things like that. So that is what I wanted to share with you. My plea, in a way, is for the skills. I think that if we together come up with, what are the key skills needed in this transformation of the health systems that we're seeing happening in front of us. And I really hope by doing that, it'll also be a way to boost the sector as a whole, and to really inspire and to hope that more young people will actually join these professions. So I'll stop here. And once again, thank you very much for inviting me. And I look forward to hearing all of the other speakers.
Thank you. Thank you for that keynote speech. And what really came to my mind was, many times when you ask people in Africa if they are like the scholars or the best scoring students in final year, what would you like to be when you grow up? And overwhelmingly, many people will be talking about, I want to be a doctor, I want to be a neurosurgeon. And Maya Matthews, you put the plea very well, and we need to really reform what this profession looks like. But let me just add one more point. I think the pandemic also taught us that if we wash our hands, we sanitize, and have hygiene practices, guess what happened? All those communicable diseases reduced. And we saw that happened dramatically. So if the doctors and health workers were showing that to many people around, imagine how we would have reduced the burden of healthcare. And it struck me when you talked about communication skills as your second pillar. Those are just my reflections. But let me thank you and invite now our second keynote speaker, Professor Agnes Binengajo. I met her when she was leading the Ministry of Health in a country, Rwanda, that you've all heard of, not only very progressive, but also in the forefront when it comes to digital health and digital innovations. Professor Binengajo is now the Vice Chancellor at the University of Global Health Equity in Rwanda, and also was the chair at the inaugural Conference for Public Health in Africa that was successfully held in December. It is my pleasure and honor to invite Professor Binengajo to take the podium. Agnes, very welcome. Over to you.
Thank you, Amit, and good afternoon to all of you from Kigali in Rwanda. It is my pleasure to joining you for this great discussion and the session of the Europe-Africa Summit. I want to talk to you as a prolongation of what has just been said and emphasize on health workforce development, the type of health workforce, not only the quantity, but the quality that we need to develop to create resilient health systems. We are still in the middle of COVID-19 pandemic, which showed us that health is a pillar of human and economic development. And we know that country needs resilient health sectors to be capable to respond to pandemics while continuing the prevention, diagnostic care and treatment needed for illnesses faced by the people in the country. And for these points, all over the world, there are very few countries who have managed to be resilient enough for people not to die from other diseases than COVID, or for people to be operated, to get surgery, to have a better life, etc. All this has been postponed. So health sectors are not resilient. And to achieve health resilience, we need to strengthen our health system from the community level to national level. Africa has a lot of expertise for the community healthcare service delivery. For example, where I'm here in Rwanda, each village has 4 community health workers across the country with standardized education and skills and pay with innovative national funding. Other countries in Africa have other expertise and experience that could serve Europe because what was missing in rich country was really a community bond and trust. And it's okay to say to the doctor, show how you wash your hands, but they are in their office. They are not in the community. They receive people in hospital and offices, not in the community. So Europe needs to learn how to provide community health services. And in the other hand, Africa seek assistance for much complicated health services like specialized health workforce for clinical and non-clinical services, for research and medical product manufacturing to ensure sustainable access to diagnostic, treatment, and follow-up in a self-sufficient manner. That's the only way to create health system resiliency. And the sustainability and the access to diagnostic and treatment. Of course, COVID has shown great solidarity and rapid innovation. However, COVID has shown also how some of our countries in Africa, the life of people didn't matter a lot for some leaders in the rich countries. So the lack of quality health education institution is also a challenge for having skilled global health workforce. For example, the legacy of colonization, despite Africa's effort to develop its health education and institution, in Africa, we have only 169 medical schools for the entire sub-Saharan Africa. This is translated in low health workforce population ratio, having 18 physicians for 100,000 people compared to 230 doctors for 100,000 people in UK and more than 300 in Spain, Switzerland, Germany, and France. So that's sure. Clinicians are missing everywhere, but they are missing more in our continent, where we have only 3% of the global health workforce and facing 24% of all the burden of disease. So we need to create, because also too many clinicians educated with African money are recruited for free by rich countries. We need to create strong legal framework for compensation and guarantee if we want our continent to be capable to invest in qualified continental workforce. If not, it will not work. And for this, the idea of a workforce observatory between our two continents, it's a good idea because it will monitor the needs of workforce, the capacity of education, and retirement on our continents. It is important to fight brain drain because it costs to Africa $2 billion a year. That is won by the rich country on the back of Africans. And education also need to change, as it was just said, with more innovation, more education on tools that are expansion of the human brain. And it helps to leapfrog and to give more services with the same number of people. But also, we need to train doctors, nurses, and other workforce in management and in advocacy, not only in communication. They know the true problem, they face it every day. And they need to be good advocates enough to convince their bosses, their colleagues, and the people they serve what to do and how to create an environment for them to exercise better what they do. Therefore, we need also, if we want to collaborate as two continents, to convince pharmaceutical partners to waive intellectual property rights and allow technology transfers. They don't have to lose money. We all know that Coca-Cola has farm everywhere. Everybody drink Coca-Cola on us, and every Coca-Cola bottle that is empty makes somebody in the US making money, and elsewhere as well. So we can find the legal framework to create this situation if we really want to work together. And if we succeed, the current situation with COVID-19 vaccine shortage will be avoided because we will have more manufacturing sites in the respect of the people who have invested in the creation of the vaccine. And we will never face again what has been a lack of access of African to life-saving tools when there were a surplus in the rich world. So because resilient health sector generate trust everywhere, if we manage to work together with decent and respectful partnership, we will have our people trusting us more, trusting science more, wearing masks, tell them to wear masks, and to learning from all of you, and wish all of us a successful summit. Thank you.
Thank you, Professor Binengajo. It's such a pleasure to have you and Maya both set the stage so well. You talked about the observatory, spot on. You mentioned about brain drain and the 2 billion cost. Some people think it's brain gain. Maybe we'll come to the Q&A or what is the difference. And we also have a structured model. And I think you also are making it very clear that almost 15 to 30 times more is what Europe enjoys in terms of health worker population ratio, making very challenging to Africa. Now we are going to call some panelists, and we're going to get into, after their interventions, into Q&A. I am really delighted that we have panelists from both Africa and Europe. With their brief interventions, I'm asking the attendees, thank you for your time, by the way, attendees I see from both continents, and thank you for your contributions and your comments so far. Put your questions on the Q&A, and at the end of this session, which is supposed to be a 90-minute session, I hope we'll use about 15 minutes for the Q&A. Let me invite Dr. Janet Muriuki, a real well-known champion in Kenya. Has been working in the healthcare workforce scene for many years. She's at the moment the Kenya Country Director for IntraHealth International, an international NGO that we all know is totally focused on the healthcare workforce. Janet, welcome. The stage is yours.
Yes, thank you very much, Amit. Good morning and good afternoon to all the panelists. I'm glad to be with you today to share on some of the work that is ongoing. And I would want to just give this work in the perspective of especially the African context. Sorry about that. And I think our eminent keynote speakers have really set the stage very well. And the issues that they have brought out are really, really pertinent. So my add to this is really around the skilling and reskilling of our profession. A lot has been happening over the last 2 years with the COVID-19 pandemic. And as we look at the health workforce, I want to look at it in terms of this schema. I think the critical one for us, and this is work that we are doing here in Kenya and also globally as IntraHealth, is really looking at curricular development and review. We are seeing an emergence of new cadres or types of health workers. We are seeing new roles being put forth by on our health workers. And we have to ensure that as we prepare this future workforce, they have the right knowledge, they have the right competencies, and this are also guided by the Ministry of Health, scopes of practice, and also the guidelines. And I think COVID has taught us a lot. We had to go back to our health workers promptly and very quickly train them on COVID-19, both those at the front line, those at the facility level, community. We had to look at our health managers. And one of the things I would just cite is providing that training, both face-to-face, and for those who are not able to take the face-to-face, is really looking at that from an online perspective. What are also the policies around this online? I think the other thing I would also want to
We may have lost Janet in the shower or the rain in Nairobi, but I'm happy to get back to Janet when she can reconnect. If the panelists and attendees don't mind, could we now skip to the second presenter, Craig? Brian, please take over. Let Craig come in and I'll reconnect with Janet after that. Brian, over to you. You can unmute.
Yes, good idea. Craig, could you just introduce yourself and take up that part, and we'll hear from Janet back in. We'll hopefully get her back in a few minutes' time after you've finished. Over to you, Craig. Craig Fitzpatrick.
Thank you, Brian, for that introduction, and thank you, ECHA and Africa Healthcare Federation for the kind introduction today. It's very important. Second summit on skills for health and skilling up the workforce. My name is Craig Fitzpatrick. I'm the WCA Program Director for Africa, and the presentation today is all around empowering providers through the use of technology. And what I'd like to start by doing is providing a little bit of background on WCA for those in attendance today that do not know anything about us, and provide a little bit of background on the work that we've been doing over the last 2 years around CPD and lifelong learning for healthcare providers in Africa. So sorry, I'm having a little bit of difficulty moving the slide forward for some reason. Just bear with me one sec. Sorry, Brian, I'm just going to continue on speaking, and I'm having difficulty with the slides here.
Okay.
So basically, so WCA is a social impact technology company, and we provide sustainable e-health and m-health learning solutions to stakeholders in lower and middle income countries. We have global partnerships with the International Council of Nurses and the World Medical Association. When WHO designated 2020 as the year of the nurse and midwife, we adopted a project called One World Project, which was around providing CPD into ministries of health, training institutions, professional associations, regulators, and healthcare facilities for free. So, so we did this in tandem with our international partners, such as the ICN and World Medical Association. So we developed a mobile app and e-learning platform, which we're going to provide white label solutions into these organizations. So we launched a project in Ghana with the Ministry of Health and the Nursing and Midwifery Council on January 16, 2020. And the overall goal was to assist countries build capacity in the training of the health workforce, namely initially nurses and midwives, but this has been extended now to include clinical officers, medical doctors, and shortly pharmacists. One of the goals was to improve access to quality evidence-based accredited education, help providers keep their skills up to date and develop new skills using technology, help them and empower them to improve patient care, which will hopefully impact positively on healthcare outcomes. So we've been rolling out this e-learning and m-learning platform over the last 2 years. To date, we've reached over 500,000 healthcare providers in Africa and delivered over 3.8 million certifications. And we're growing at a rate of around 15 to 20,000 healthcare providers a month onboarding onto the platform. This partnership would not be possible without the help of our education providers. So we work in tandem with a lot of the NGOs, such as WHO Africa, UNFPA, UNICEF, JPIGO, Liverpool School of Tropical Medicine. And we also are working more and more with African-based educators. We've done projects with Aga Khan, University of Cape Town, Knowledge Translation Unit. And of course, we also work with the Royal Colleges in the UK, the NHS, Health Education England, and many others. So we have a large resource of quality evidence-based training, which we make available for free to healthcare providers in Africa. I think one of the things that's been highlighted by all the speakers so far has been around human resources for healthcare. And I think obviously WHO has highlighted it in many reports that in order to achieve universal health coverage, 18 million will be required by 2030. 9 million of those are nurses and midwives, and the majority of these are required in lower middle income countries. So in order to, I suppose, to overcome a lot of these problems due to human resource healthcare shortages, it's imperative that CPD and technology is embraced as a methodology of developing a more highly skilled workforce, empowering providers as part of health system strengthening. So we initially started this project just as a synchronous platform, but because of our ability to connect with such a large community of healthcare providers, this has been, should I say, this has now been extended to include other forms of technology as a medium of training the workforce. So our platform at the moment delivers e-learning and also m-learning, which allows providers to study online and offline, which is very important, especially in the lower cadres of clinical health workers and nurses and midwives, where access to computers is a lot lower than doctors and nurses. We've also embedded Zoom into our technology, which allows us to connect with healthcare providers quite easily. using virtual learning. We've done a number of webinars on the labour care guide with the 3 UN agencies. I've been able to attract over 4,000 attendees to 4 webinars, and 680 of those attended the 3 webinars consecutively. So the third aspect is clinical and simulation training. So as part of our development and the evolution of WCA in Africa, and also working more closely with local consultants and the key stakeholders locally, we've updated our platform to make sure that it can also do blended learning. And we've a number of projects on the go at the moment in conjunction with Liverpool School of Tropical Medicine, on advanced obstetric and anesthesia skills in Kenya, with doctors. So we've got 58 doctors using our platform for virtual e-learning, and the clinical aspect will then follow later on, and this has been extended into Nigeria in early 2022. We've also got projects with the Ghana College of Nurses and Midwives in Toronto Kids Hospital as part of a research program around behavioral change and COVID-19 in Ghana. And we have many more blended learning projects in the pipeline with Jupaigo on HIV and TB. This year, the Global Business School Network around leadership and management, empowering nurses and midwives, around advocacy for more nurses and midwives having a bigger part to play in health system development in countries. And another project with Liverpool School of Tropical Medicine on midwifery educator and trainers around midwifery education. As we know, maternal newborn health is a key capacity building area for most governments in Africa. So what have we learned over the last 2 years, and what is next as far as WCA and contributing towards upskilling health workers in Africa? Well, through our AI and detailed analytical tools, we've been able to analyze the behavior of providers over the last 2 years. And it's clear many providers are using CPD just as a box ticking exercise, and it's not structured towards really developing skill sets and making them more specialized in their area of practice. So thanks to a grant from the Johnson & Johnson Foundation, we are embarking on 2 trials around skill gaps and learning pathways for nurses and midwives. We're starting the projects in Ghana and Kenya to start, but we're hoping to roll that out to the rest of Africa on completion of the trial. So we're working with the ministries of health, the regulatory bodies, and the professional associations, bringing all the key stakeholders in, looking at areas that really need capacity building and building in those learning pathways in conjunction with some NGOs and local providers as well that we're going to be working with. And in the third quarter of 2022, we also hope to build in a telemedicine application into our app, which allows providers in Africa to communicate with diaspora working overseas in the UK and America, and solve problems on the job. So that's a little bit about WCA and what we've been trying to do to contribute towards skills development within the health workforce in Africa. And thank you for the opportunity to speak today.
Over to you, Amit.
No, thank you. Craig, you're really busy. I wish you all the best with all this Johnson & Johnson Foundation work, skills gap work. You mentioned Ghana, Kenya, some other countries. Please place your website link onto the chat box so all the attendees and all of us can see more details of the work that you do. And some of us may want to contact you to expand into some of the other areas. Janet, you're back. I want to bring in Janet before Dr. Atoki from Nigeria, and then we'll move to Manuel. I think 6-7 minutes each panelist would be great. Then we could do a roundup and we'll have some key questions. Salim and Mary have already started putting some Q&A. Prof. Agnes and Maya, if you guys want to start looking at some responses, please go ahead. Janet, welcome back.
Thank you very much. Apologies for that disruption. We did have power blackout. We are having a bit of some rain. Yes, so I think I will just catch up from where I left. I think based on the schema I had shared, I think looking at the skilling of our health workforce beyond curriculum and development and review, and taking into everything context, COVID, the other critical element to really look at is faculty capacity development and mentorship. And this is what we have done here as IntraHealth, working with across 18 medical training universities and colleges, really supporting them to put the latest Ministry of Health guidelines, teaching faculty on pedagogy, andragogy, and most importantly, also creating a relationship between institutions where there's mentorship between themselves within and also outside. Looking also at the policy environment, here in Kenya, we have developed, and even in Mali, we have developed training policies. We have looked at user manuals that can guide both pre-service and also in-service, working also with the regulatory bodies, the councils, the professional associations, to ensure that they are stakeholders and buy into some of these policies, because as regulators, they also are ensuring their implementation. I think the other thing when we look at the skilling and reskilling of our workforce is, where are these students at pre-service level getting their experience, the placement sites? Are they accredited? Are they meeting the required standards, so that as these health workers go out there, they're really thinking around quality and are exposed also to the best standards of in terms of service delivery. Those internship centers are also really critical. We have developed internship guidelines. In Mali, we have also looked at placement guidelines, which are also critical. The other thing really also around the medical training institutions is looking around resources for them to continue growing their training infrastructure and also increase the capacity of the students that they can support. And there are a couple of ways this is possible. Having the resource mobilization committees in place, working around with them to put in place strategic plans, business cases, taking them to financials. We have worked with one of our institutions, that is one university, taking them to the government, public-private sector, PPP unit, and really help them actually realize feasibility study to expand their medical college. And these are possible and can be replicated. The other thing about the infrastructure that is critical is, as we train, are we drawing away these health workers from their workstation? We need to take up models that encourage these health workers to be trained at their point of service delivery, to be trained in the field and get that exposure. In Africa, we have the COSEXA model, whereby you could train oncology nurses within hospitals, and they continue providing services. Surgeons can also be trained, both orthopedic and general surgeons. So I think we need to model on this, create those excellent centers of excellence. Why should people be going to India? And I think this is possible in Africa, where these facilities are actually set up and offer training and service provision is happening. We're also removing our doctors from the rural areas, or the nurses, and training them in the urban areas. Why not have these centers of excellence also in these rural and hardship areas? And I think we'll have better retention of both our basic frontline health workers and those that are providing specialty services. And I think the last bubble for me there is really about partnership and collaboration. In the reskilling, what are we hearing from our alumni when we do research for them? Are they fit for the market? Are they, what areas are they still having gaps in, so that they can become relevant? We talked about a digital area. Do they have those skills, digital skills? Do we also have, for example, our M&D and health records officer? Are we teaching them to be data scientists, so that they can critique this data more and really bring back information that can guide the decision makers? At collaborations within schools and departments within our universities and colleges? Is research guiding our curriculum? Is research guiding what the market requires these institutions to do? So they need to pick up on this mandate and ensure that those collaborations are harnessed. Lastly is a collaboration between government, both national and subnational, the private sector, and the FBO when it comes to skilling of our health workforce. This is critical to ensure that we are capturing everybody. It's not just government leading and the private sector or the faith-based sector is not being able to collaborate and also implement what is required based on the disease dynamics that are playing out in every country, and especially now with COVID. I think the very last one that I wanted to share on is a model we have put out here in Kenya known as the Afya Elimu Fund. And this is a collaboration with the higher education loans, both the private sector led by the Kenya Healthcare Federation. And this has actually what has grown into the Africa Healthcare Federation. This has given us very good results. And I have to say, when we look at our skilling, we also need to look at the family setup, at the resources within the family. If not, these students need to be provided for low income, low interest rate loans that can support them undertake their medical education. And this will ensure that the students go out there into their community, whether they're coming from the marginalized areas, and are able to provide services regardless. These graduates, again, need to be employed both by the public, private, and FBO sector, and therefore become useful members of our society, really having an impact on service delivery. Thank you very much for your listening, for listening to me. We look forward to engaging with you all in propelling this work beyond Kenya and into other African regions to ensure that we have a responsive workforce that is fit to provide the requisite services. Thank you.
Thank you. Thank you so much, Janet. You know, I was involved in the Afya Elimu Fund. When I see these numbers, it started from virtually zero. Imagine the number of health workers we've been able to put in the system because of this unique funding mechanism of a moratorium and paying only 4% back. If it's affordable, many people can go to medical school and health colleges. So I congratulate you for that initiative on that collaboration and partnership. It's my pleasure now to bring the next panelist, Dr. Morez Atoki. She is dialing in from Nigeria. It has been said by the CEO Aliko Dangote Foundation and the board member of ABC Health that she has a strong track record for execution. She has good communication skills, which I know, but most of all, she's got great leadership capabilities. She was appointed the CEO of ABC Health at a time when Africa clearly needed a strong convener of all stakeholders in public and private sectors to deepen partnership and collaboration, exactly the bubble that Janet told us. It's really a pleasure to have you with us. Dr. Atoki, the floor is yours.
Thank you so much, Dr. Amit, and good afternoon from Nigeria, West Africa, to all of you. I'm very pleasure to be here today to talk to this particular topic. I'm struggling to put on my camera. I don't know whether the technical team can support me in doing this, but apologies if I'm unable to do that. I probably would. I'm getting a pop-up to do so, but it says cannot start video. Nevertheless, that's still fine. Let's say if I can share my screen. I have a presentation, just a minute.
Are you able to share your screen, Atoki? And could you help with the camera and maybe technological access?
Absolutely. I can certainly share your screen for you, Dr. Toki. I have been making a request for you to share your camera, but you have some difficulty. So I'll share your slides for you.
Please do.
Excellent.
Right, thank you so much, Eva. Right, so with a lot of regard for all of the areas that have been mentioned by the earlier speakers, the panelists and the keynote speakers, what I did was talk a bit about the issues around health, largely in Africa. And it starts saying that the issue of skilling up the workforce, the incapacity of the workforce, seems to reoccur significantly in Africa. So, for instance, we do see that compared to the need, we produce the lowest number of basic health products. Also, our problems reflect majorly primary health problems, infectious diseases, multinational diseases and diseases arising from environmental problems. However, the spectrum of this African system, just a minute, been limited by banning the production of some of this mid-level human resources that is required. Please, next slide. Still on the same issues, we reflected on some of the fact that health workers serve the minority of the population. Also that international leading organization policies have severely restricted access to the poor, while at the same time the volume of international investment required to make a difference seems to be well below the levels needed. About 70% of Africa's population still sees traditional health practitioners. And in many parts of the continent, the curriculum of health training schools tend to focus and reflect on health problems as against the needs. They reflect on the health problems as though were compared to the needs of the industrialized countries. Next slide, please. Still on the key paradoxes. Went a bit into the magnitude of the crisis. What exactly is responsible for this? And I did reflect on some of the areas that WHO had identified. The threshold in the workforce density with high coverage of essential interventions, including those necessary to meet health-related SDGs, has been concluded to be unlikely, considering the facilities on hand, the size of the healthcare skilled health workers that we have. And then lastly, we talked about the skills and the pay structures of these health workers in sub-Saharan Africa, the adequacy of the income for health workers, the management of the public sector pay, the fiscal and macroeconomic factors that impinge on the highly and important role in scaling up the Africa's workforce. These are major issues that contribute to the unskilled workforce across Africa. This is talking to 24% disease burdens, marching to 3% healthcare workforce by 2030. That's a significant number. Next slide. And in the next couple of slides, what we dwelt on was some of the reasons what are causing this: macroeconomic and fiscal constraints, international health worker migration, the paucity of information and data and human resources for health, the quality, the value from trade health workers, as well as low performances, skills mix and skill levels. Next slide. I'm aware that I have just 15 minutes, so I'm trying to hurry up the slides. Still on the causes, the availability of health workers being severely limited in terms of number, skills, and distribution. poor HR planning and information systems. The performance of these health workers has been hampered by curriculums, produce well qualified cadres, but create skills and competencies deficit. Leadership and stewardship of health systems in Africa. Some studies recognize that epidemiological and demographic transitions in Africa cause a mix of both developed and developing country diseases. An added factor to almost condition government proposals for funding to routinely avoid human resources issues. Next slide. And the why continues until we get to what the targets are. Next slide, please. Yes, I wanted us to have a bit of reflection on, can we go to the next, not this one, on the targets by the WHO, the next slide to this, please. So this continues in terms of the reasons why we have this unskilled, healthcare workforce. And we see here that the WHO mentions that what needs to be done to address the current situation in healthcare and the skills of its healthcare workforce is contained in a framework for the implementation of the global strategy of human resource health workforce in the African region. The target is that is expected that by 2020, which we're in, all countries in Africa must put a mechanism in place to coordinate HWF agenda, healthcare workforce agenda. At least 23 countries in the region should have established accreditation mechanism for health training institutions, HRH investment plan based on the current and future needs. And we have that by 20, all of the 47 countries in the region should have achieved all the above and should have reduced at least by half inequalities in access to a health worker and have reached at least 80% of the course completion rates in medical, nursing, and allied health professional training institutions. In addition to providing technical support for planning and implementing the proposed actions. Next slide. Now, reflecting on these targets, a couple of studies have been done, particularly by the African Working Group membership, considering the urgency that the group feels is needed to resolve the crisis. And some of the solutions we'll see in this next couple of slides. Next. The first one is advocacy. I do strongly believe that there's still not enough of advocating this particular issue across countries in Africa. The large portion of the responsibility still resides with the government, public health. And without advocacy, mindsets of key stakeholders are not likely to change. The process for action in countries also needs to be looked at from the human resources point of view. Country solutions have to be tailored to specific needs, and they must recognize that these actions require longer time frame to demonstrate the effect of implementation. There are also country-level actions that are required. Policymakers at all levels, global, international, regional, civil society groups, development partners, associations representing health professionals, regulatory bodies and agencies, as well as private sector. There needs to be different levels of engagement and actions by these key stakeholders for advocacy and also consultation. And until we get there, until there is that level of partnership and collaboration with the key stakeholders, there's likely to be just a lot of talk and not a lot of complaints and not real actions. Next slide. Again, initiating the process to change will require a number of steps: stakeholder forums, of solutions and innovations, I did hear the previous speaker talk about digital health. Yes, perhaps this is the time to critically look at it, its pros and cons, and leverage highly on the pros. However, I think it's just really important to say that Africa has fundamental, health problems and health challenges. The healthcare workforce and the skill set, presently that they have is one of the major ones. But against their infrastructure, there are so many other problems that surround it, questionable leadership, infrastructure deficit, and so on and so forth. So my situation with the digital, health provision is that we don't do the same thing. We don't fail by just assuming that we will copy and paste and have it solve all the problems. I do think that a large part of the skill sets, the issues in the Africa healthcare needs to be customized and localized to the specific health care needs, as well as the health care workforce needs of the areas and of the countries in question. Also, developing the solutions and innovations needs to be feasible, it needs to be customized. And then implementation of the action plan, which gives a mandate to implement actions to determine the feasible, also include a monitoring and evaluating process. Next slide. We talked a lot about government actions. Why do we keep having all of this? I mean, there's significant studies that have been done. Some are that health workers in Africa feel neglected and not valued. Some point at the HIV straw that broke the camel's back in Africa. Also that health workers who previously coped with staff shortages, consider the COVID-19, the pandemic, have now been overstretched by the pandemic. Again, to meet the challenge, Africa Health Service needs to rescue the health workforce from the disease through availability of counseling and treatment programs. Some of them are not even available. So the healthcare, the workforce, the healthcare workforce is becoming more and more unattractive. We imagine that what's the death toll that Africa healthcare workforce has recorded over time, especially during this pandemic, only just distracts potential students from focusing on studying, health-based academics. Again, the experience of actions in African countries, the lessons learned are hampered by the lack of operations research, as well as M&E. Next slide, please. And I want us to quickly get to the solutions. We talked about the policy options to respond to the crisis. One of it is reviving the alma ata approach. A renewed focus should be on the production and support of appropriately trained primary health workers that can adequately respond to the health needs of the poor and other vulnerable groups by enhancing access. Retention of critical professionals, doctors, nurses, midwives, pharmacists, and so on and so forth. Managing HR strategies and financial constraints is also really quite key, because this largely affects health services that each country requires. And this should seriously consider expansion of the roles of mid-level health workers that perform clinical and nursing tasks at primary care levels. Lastly, we have the planning and management roles within countries. Can you scroll, please? Or you go to the next slide. The need, please, the previous slide. Global international levels, kind of interactions, necessary actions and monitoring of how best this human resource health is utilized in countries We must build capacity for countries in human resource for health, and then regional and sub-regional development of a network of human resource for health expert researchers and practitioners that can support countries' efforts at evolving and implementing strategies. Next slide. This is the last slide, and it talks to the urgency and the need for an immediate response. It's highly recommended that certain actions must take place within the next couple of years to lay the foundation for future actions and strategies, but also to address immediate emergencies. One of it is the health governance systems, which includes criteria and monitoring peer reviews that are corollary to leadership development. The African region, sub-region will be well served by setting up a regional, sub-regional observatory monitoring institution and systems that can independently monitor and evaluate countries' experiences and serve as a knowledge sharing facility for experts and countries in the region. There are other long-term actions that are needed for the quick evolution of the strategies can assist regions to stabilize and begin to sustain health by focusing on skilling the healthcare workforce at a regional basis. And I think that is my last slide. Is there a next?
Thank you, Dr. Atoki. Yeah, those are your references, and you shared quite a deep set. Please share this with the participants and the panelists. It will be useful. Brian, I would now like to turn it over to you. Many thanks, Dr. Atoki. We'll come back on the Q&A.
Right.
Brian, you want to unmute?
And I thought I was getting good at Zoom. We're now moving on to Julie Cortner from the Connected Health Group in Ireland. I should declare my interest in this in that I'm the chairman of this company, but it shouldn't preclude Julie from talking to us about her experience of skills for the workforce. So over to you, Julie.
Okay, thank you. Oh, okay.
You sharing? Yeah, there you go.
All right. Okay, thank you so much for inviting us to participate today. It's been a very interesting conference so far, and I know I personally have learned a lot. I suppose I want to introduce you a little bit to the Connected Health Group. Our group was established back in 2013, and we work across 3 jurisdictions. So we are based in Northern Ireland, the Republic of Ireland, and GB, which is Great Britain. We have 11 offices, and we have almost 1,300 carers out delivering care in the community. Each of our regions has unique standards that we must follow, not just on care delivery, but the training and the skills that each region requires. The group, and with Brian's leadership, obviously had the foresight to see how important training is and created a bespoke training academy, and we call it our Connected Academy. We operate on the 3 T principles of talent, which is getting the right people, training, ensuring that they have the appropriate skills, and technology, where we try to work as smartly as possible to deliver an enhanced service and deliver what we call our home care 2.0. So what we've discovered is that people are very much happiest when living at home in familiar surroundings, especially as they enter older age, and allowing them to remain independent at home is very much our key purpose in our service. We've seen an increasing demand for social care with more complex conditions and a requirement to provide clinical services at home. Our carers very much need to take a holistic view of the person, looking at their health and well-being, and not just providing a standard home care service to prevent health deterioration. These demands have made it evident to us that we really needed to create professional skills for carers. So it's hard to believe that it's almost 2 years that we have lived through a pandemic. COVID has highlighted the importance of home care, and the statistics on the number of deaths compared to nursing homes were stark in that health care at home was minimal amounts of deaths compared to what was in a nursing home. So therefore, the demand for community care increased during the pandemic, and it is highlighted again in the current wave, and the need for urgent hospital discharges to free up beds. Ultimately, we are requiring more people to come into social care with the relevant skills. So the Connected Academy provides recognition and validation for our workforce. They deserve the skills and the knowledge to meet the increasing needs. And the Connected Academy has delivered or developed programs to enhance care that is delivered. We provide accredited training, give the carers the confidence to deliver services to the most vulnerable. So our timeline really is to give you an idea of the history. So the company was established in 2013. By 2017, we created the dedicated Connected Academy to enhance the skills. We then opened an accredited training centre working with the Open College Network in 2018. And then by 2019, we had won our first awards for the services that we provided. We also then introduced an online platform for our mandatory training. This was very good for facilitating the refresher training that needs to be carried out sometimes every 6 months by the carers. In 2021, we attained further accreditations and got more courses approved by OCN. And in 2022, we plan to take the Academy international. All right. So looking at our onboarding process for our new recruits, COVID resulted in us sort of maybe having to create much more of a virtual process for interviews and assessments and bringing people into the company. The introduction of our online platform made it much more convenient and accessible for everyone. We also use technology and by the use of devices like a tablet in the field to carry out assessments with our carers and our clients and identify any issues which can be addressed by additional training. The carers can also consult the online platform for refresher training if they come across an issue they are unsure of whenever they're out on the ground, which is very important because quite often they're a lone worker. We have 5 levels of training, and that's we begin with our level 1, which is an endorsed course of safe practice of a care assistant. And that's our sort of like mandatory starter place. The Academy put 919 people through this training in 2021. And then we follow on with a level 2, and that's our supervisory training and resilience course, which we would call our STAR program. And this is sort of to introduce new leaders into the business. And we put 81 people through that course in 2021. We also then have a level 3 course for leadership and excellence in development, which we know is our lead program. And we have put 85 people through this program. Our level 3 diploma then for health and social care is sort of our a further management level. And we had 24 go through this course. And we our last sort of highest level, of course, is a level 5, which is the senior management level. And we had 8 people complete this course in 2021. So we also have very much a career pathway. We want our recruits, whenever they join, to feel that there's very much a clear career path. We can offer a clinical pathway by upskilling for more complex care. And then we have a social wellbeing pathway for those interested in wellbeing and improving the mental health through the use of technology whilst delivering care. And there is also the traditional career path of leadership and supervision. In fact, our director of care began her career with us as a part-time carer. And today she is a director over all 3 jurisdictions. So that's really the end of our presentation. We just wanted to give you a very short insight into the business, our contact details are here. And as I say, unfortunately, my colleague Teresa, who is our Director of Clinical Services, was unwell today. So I have stepped in last minute to give you a little bit of an overview for us. So thank you for your time.
Thanks very much indeed, Julie. Just to say to everyone that this is a departure from some of the other presentations we received, because this is about care as opposed to necessarily doctors, nurses, and so on. Though I must say as well, we're getting more and more requests for at-home care to be conducted by nurses and so on. So I think this again, there's a huge shortage here again of carers. It just is just as simple as that. And if we could find another 1,000 carers now in the 3 jurisdictions, we would employ them. And we're doing our best to do that. But it's just to give you another aspect of this very complex, I think, market that we have to think of. We have to think very cleverly as to how we overcome things. We want to watch the time. So we're moving on then to Emmanuel. Welcome back, Emmanuel. We're delighted that you could join us again. And thank you for your support for this summit. Would you like to proceed with your slides? I think you've got them there. Yeah.
Yeah, thank you. Thank you very much. Thanks for having me. I am between you and the Q&A, so I will try to be as short as possible. So basically, I am Emmanuel Blanc. I am the founder and CEO of Take Care for All. That's a company I created in 2017 with the idea at that time that the digital health revolution would disproportionately benefit low-resource countries and low-resource settings, which is actually what we have been seeing live during the pandemic. So I created this company. We are operating uniquely in Africa and in India. And we are dedicated to accelerating SDG-free execution through enabling digital health solutions to be used and utilized appropriately in Sub-Saharan Africa and in India. I am operating from Brussels, but 100% of my people are not in Europe. They are in Africa and in India. We have offices in Senegal, in Nigeria, in Nairobi, and in India. And I'm very happy today to talk about the topic of upskilling the workforce, because that's at the core of what we are doing now, especially since the beginning of COVID-19. So I will come back to that. So I will maybe start with 2 examples of what are we really talking about here in terms of the need to skill up the workforce, the healthcare workforce in Africa and in India. So 2 examples of the reality of the need. So if you look, for example, at the topic of maternal and newborn care, MNCH in the jargon of global health, there has been a lot of progress in terms of access to care, even in Sub-Saharan Africa and in India. And today we are in a situation where quality of care is as important as access to appropriate care. And when it comes to quality of care, clearly, being able to continuously train and certify the healthcare professionals who are dealing with maternal and newborn care is a fundamental priority, a fundamental topic. And you see efforts of the global health players and actors and stakeholders moving into that field of how do we ensure quality through training. So that's a fundamental shift that really illustrates the importance of upskilling healthcare workers in our countries, in Africa and in India. A second example is in cancer care. So, I mean, cancer becoming more and more of a focus in Africa. I mean, the WHO is really insisting on the fact that this is becoming slowly but surely a major burden for countries in Africa. And here, I mean, whilst access to care continues to be a significant issue, clearly there are issues around knowledge and skill gaps in the healthcare workforce when it comes to the diagnosis and the treatment of cancer. And it's not anecdotal. I mean, when you look at 5-year survival rates in Africa versus the US, it's 59 versus 90%. So the gap is huge. And some of that gap could be filled through actually proper training, proper ongoing continuous training of healthcare workers in Africa. So 2 examples to share about the importance of what we are talking about when it comes to patients, when it comes to survival, when it comes to avoiding deaths which are avoidable. So in that context, what COVID has shown, and I think has shown for everyone, is that in-person training, physical training, the way it was done traditionally in hotels, in facilities, one-off events are not necessarily what is the most efficient way to train people who are incredibly busy, who don't have necessarily the resources to travel, to attend meetings. It's very difficult through those physical meetings to reach people who live in rural areas. And very, very importantly, we are learning all together as a community that training doesn't stop with training. Training actually starts after a training session, and the ability to follow up, to monitor, to certify, continuously reassess knowledge and skills is fundamental. And that's where the digital tools and digital training and e-learning is a fundamental improvement in the way we can actually upskill the workforce in Africa and India. And to that issue of follow-up, just to give you an example of one of the biggest programs we are currently running for a big foundation, it's the area of prostate and breast cancer in Africa. And it's really building a continuum of training programs in different countries around not only training, but making sure that the training that has been provided is actually used, is actually improving care, is reassessed, is continuously monitored. So a very significant investment there to try to tackle the 2 biggest cancers in Africa today, prostate and breast. Examples of what we do in that spirit. So, for example, one of the biggest NGOs, Population Services, is using us to train their own people, but as well their clinics, and not only on clinical things, but as well on administrative things and tools they are using to improve the way they work and make them more productive. Another example is a big program we are running for UNFPA, the World Bank, in Sahelian countries around empowering women. A lot of that program has switched to things related to COVID-19. And this is a way for me to tell you that what we have been building is a tool that is called the Medical Learning Hub. That is really a tool that connects trainers to trainees. So any training organization, and we believe that healthcare is an ecosystem where we have governments training, we have NGOs training, we have academic centers, key opinion leaders, specialists based in Africa training. We have pharmaceutical companies training on their innovative drugs. We have medtech companies training on their innovative interventions. We have medical associations training their members. We have networks of community health workers training their members. So we are agnostic to who is providing training because we believe healthcare is an ecosystem. And as long as the quality is there, as long as it's about monitoring and making sure that people are actually learning and doing something with what they learn, we believe that it's worth investing into disseminating this knowledge. So we are hosting a lot of content from a lot of different training organizations. And of course, we connect those training contents to trainees, mainly physicians. We are highly focused on physicians for now, and as well empowering physicians to train, nurses, midwives, and community health workers, but we are highly focused on the physicians. We accommodate any sort of training execution, whether you are talking about webinars, online recorded, true e-learning sessions for our own LMS. We can accommodate hybrid training programs as well, which include both face-to-face, physical, and learning sessions. So that's a marketplace that is growing very, very fast in Africa and in India. We now have more than 350,000 physicians online. We are growing at a high speed, and thank you for our attention. I'm stopping there. Thank you.
Thank you, Emmanuel. And I'm afraid we're running out of time. We don't want to keep attendees, but there are some really burning issues. Your presentations, please, Heather, if you can share it with all the attendees there. Tech for All, your support is invaluable to us. So brain drain. I'm going to come to Professor Agnes, and then I'm going to, of course, ask Maya to talk about regulation, both in Europe and Africa. Lots of questions on brain drain. You're telling us we shouldn't have brain drain, but Cameroon has also said you're not employing. So please don't leave Africa stay in Africa, but then it is joblessness. It's a disaster. It can be a disaster. Agnes, over to you.
So I don't know which type of health professional has problem in Cameroon. I don't know if they are well trained by the system and appreciated by the system, or not appreciated, not recruited. But as far as I know, the health sector in Cameroon complain about not having enough professional, but you know, we are not everywhere. We can talk about what we do. And I want to say what we do here to stop the brain drain. Janet, you talk about creating health education facilities in rural area. Our university, which is a great one, by the way, is in the rural north, really. And we have created a state-of-the-art, enjoyable place and show to the students that we can live in rural area. And this is normal because we educate young people in cities, and after that, we want them to go and work in rural area. They are between 20 and 30 years. They believe their life is finished. No pub, no cinema, my friends, blah, blah, blah. Educate them where they are needed. Also give them a community-based education. Of course, institutionalize also the education, but not only like we do. We educate in home-based care. They are doing rotation with community health workers, and they really are embedded in community. We educate doctors for free. They don't run after even free, almost free loan. Push people to run after money, so they go in cities, make money, mistreat people, to see a lot of people, to reimburse quickly. So we don't solve the problem. In the US, we have seen that people have debt for more than 20 years. So we educate for free. However, they sign an agreement that they will work 9 years for their full salaries as doctor in a public sector, and none are unemployed. We call that umusanzu. They are not obliged. If they don't want, they go in another university. But if they work with us, we sign with the ministry, we have this young person sign already that you will employ them, and they sign that they will employ. If not, they will reimburse all the education. So there is a way to fight brain drain. There is a way to educate community-based as the people we want, but you need to improve also the quality of how you educate. That's what I wanted to say.
Okay.
And congratulations to all the panelists. I learned a lot, but I have to leave you. And I was so pleased to be with all of you.
Thank you for your time, Professor.
Thank you, Agnes.
We'll be calling upon you. We'll continue. This is just the beginning of the collaboration, but your input is truly valuable. Let me now thank you for being with us. Let me bring on Maya Matthews. Maya, there's been a lot of discussion between Europe and Africa, and apologies for the attendees and the panelists. I would like to just, request you for about 10 more minutes to wind up. Those of you to log off, I understand. Maya, is regulation strangling the progress of healthcare workforce? And also, before we go about regulation, if you want to talk about this, are you picking health workers from Africa where there's already a desert, making it even more dry? How should it be well organized? Over to you.
Thank you. I'm going to skirt around that issue because I think it is an issue that we definitely know about. I worked in Geneva before and worked very closely with WHO, and I know that we are doing all we can. I wanted to actually talk about brain drain within Europe because I think maybe not everyone is aware of that okay. Europe is also a big continent, and there are moves. And in Europe, we have a single market where there's the free circulation of people. So it's much harder to do the things that the professor was talking about, because part of being Europe is that you're in a single market where people can move freely. So I think that you're right, and I very much appreciate what the professor said, because it is about educating, but it's also about providing incentives. That's where I think training is a very important thing, that if people feel that they are valued, that working and becoming a health professional, there's also something in it for you. It's about prestige. There's a whole caveat to what motivates people in their jobs. And this is what's very worrying, what we're seeing in Europe at least, is that funnily enough, during the pandemic, we've seen that the rates of application applications for health jobs to be trained, at undergraduate level are increasing. So that's a good thing. But then there seems to be somewhere in the middle, after maybe 2 to 5 years of working, that people are leaving the profession. And I would say that I think it's very important to try to drill down and find what are the underlying factors there. What is it that's making people, after having, in a lot of cases, spent many years training, to want to leave the profession? So we are just quickly, I will finish now, but just within the EU, we have created a group, it's called a joint action with governments, with national health authorities, to look at the planning and forecasting, and of course, looking at where the health workforce is coming. And I know that this is a very sensitive matter, and we are all very cognizant of this. And I can tell you one of the reasons why we're trying to push training is really to try to develop more health workforce within Europe. But I think this is a key question across the world, is to say that what is it now that is, is it not an attractive profession anymore? Where is the status and prestige? As I said in my earlier speech, the relationship, the power dynamic between a health professional and a patient has changed. People go onto the internet. They think that they know, they can get all the information they need. So I think there's a lot of very interesting and complex issues that need to be discussed. It's not as simple. Nothing interesting is simple. That's what I like to say. But I really enjoyed hearing all the panelists, and I think that there's so much rich ideas and so much creativity as well. So I really hope that this will continue, and we can share ideas and projects together. Thank you.
Thank you, Maya. That's really illuminating. As I said, this is the beginning. Can I also thank Charity, Kate Tulenko, Richard, I've got Michael Mabo, and Salim Hasham, Mary, Dr. Mary, all the people who've been writing some amazing questions. We're not able to answer all of them, but at least in these discussions, we are touching on a few things. I think it'd be right to give every panelist a parting shot for the attendees who've been able to stay with us. Let me start with Janet to just give her parting shot, and I'll go in order of how they spoke, and then Brian, I'll come to you to wrap up. Okay. Janet? Yeah.
Yes, thank you very much. All great discussions this evening or this afternoon. And I think for me, my parting shot really is what's really critical is partnerships and collaboration. Mm-hmm. We need to partner with government, both at national and subnational level. We need to look with research institutions. We need to collaborate with our alumni to really know those who are out there in the market, are they fit for purpose? And I think that's the only way that we will know whether the skilling that is happening at pre-service level, at in-service level, is actually having impact and providing quality service towards universal health coverage. Thank you very much for your attention.
Thank you, Janet. Let me invite now Craig. I think he's left us. So could I move to now, Dr. Atoki, we can see you. Your camera is working. Your parting shot for us.
Yeah, and thank you so much, Dr. Amit. My parting words will be, I think a lot more needs to be concentrated around localizing these problems so that the solutions are equally localized. I see a lot of attempts to assume that because solutions have been brought out in some parts of the world, we can replicate the same without necessarily, taking the pain to look at the very granular details of our issues as Africans. What exactly is informing these issues? What are the underlying responsible things for these issues? I think until we dig deeper, we can actually be channeled in the direction of, just pasting the solutions as we have them in other parts of the world. And I think a critical approach in that direction might actually be really quite useful. Over.
Thank you. Spot on. Localized solutions on the ground. Julie, I want to call you over for your parting shots.
Okay, well, thank you. I'm going to stick with what I know, and I think one of the things is empowering social care workers. and realizing the power of the care in the community, that it doesn't all have to be clinical expertise in terms of nurses and doctors, that there's an awful lot can be delivered by local people caring for local people in their communities, and by providing skills to them, we can make a huge difference.
Exactly. Healthcare starts at the homestead and not at the hospital doorstep. And I think that's what you're trying to tell us. Emmanuel, let me bring you in now for your parting shots.
Yeah, I simply think that, physicians, nurses, midwives, community health workers, they dedicated their life to saving the life of others. That's what their life is about. So investing in training those people, investing in those people is a duty we all have. And it has a double win. It will save lives, and it will keep them engaged, motivated, and hopefully working where they are working as well.
So right. Frontline, they are the heroes, true heroes, and you couldn't have said it better. I think we've done pretty well. Let me invite Brian. Now, thank you, Brian. This partnership within Europe and Africa is working well. Let's keep it going. Over to you to give us a wrap up and wind up the session. Thank you. You want to unmute, Brian?
I thought it was, you think I would know by now, wouldn't you? But anyway, I'm always learning. Anyway, I want to say, particularly, Dr. Atoki mentioned something about what I call cut and paste. There are too many people in the world who think that if something works somewhere, it ought to work everywhere. And the reality is it doesn't. You have to localize it, but more importantly, you have to have the buy-in of the local community. Andy from the Alliance does this every day of the week, working with our 70 ecosystems. And you talk about Africa, you talk about across Europe. This morning, I attended a meeting of a lot of our ecosystems across Europe, and you can't say something in Sweden will work in Belgium, and we heard that this morning, but we can learn enough from each other and localize, as you say, Dr. Atoki, and that's why it works. You have to have people who believe it's theirs, not someone else's. You've got to make it our solution. Finally, to say, this is, as Amit said, the beginning, not the end. We will be in touch with all of you with all the presentations. We're more than happy to facilitate connections between each of you. And we will continue these summits. But just final thing is, we also have to do things. So yes, we can meet for a summit. Quite comfortable. It's quite enjoyable actually to sit and listen to everyone. And I've learned a lot as well. But I am a great one for specific actions. So maybe, Amit, if you and I could agree that the Federation and the Alliance will put together a summary of this, but also listing a couple of actions we should take. And I've written a few of them down. I won't share them now. We could maybe have a chat and then we'll share that with everyone. But everyone has to help us. We can maybe lead a little bit, but we need your, not just input, and that's good, keep doing it. We need you to do it as well and involve all of us in this community. So thank you all very much indeed. And thank you, Amit, for our partnership.
Thank you, everyone. Have a lovely evening. Have a lovely afternoon. We'll stay connected. Bye, Brian. Bye, attendees.
Bye, everyone. Thank you. Thanks very much indeed. Bye-bye.